Any idea what is the importance of May 28th? Suddenly I am wondering why I am asking you this question. Any idea? Something is thinking. Any idea why May 28th? Today is only January. But why I am talking about May 28th? World Menstruation Day, okay? Very good.
World Menstruation Hygiene Day.
How come when you know about this? Great. That's actually World Menstrual Hygiene Day. Someone may be good at, picking up all this. This is to 1 to all the 365 days you may know every day. What is 14th February? Don't behave as if you don't know. What is it? Come on.
But then again, it could one more attack.
So you are good at identifying which day is for what. Okay, fine. Any other important days to remember? When is your father's birthday? You know. Okay, that's good. Fine. So there are certain important dates which you would like to remember. Obviously, no one will like to remember World Menstrual Hygiene Day. But having said that, I think as doctors, all of us should be aware of that, and not just why are these days celebrated? Is it because one day we celebrated it? Okay, you give some significance. At least then people will realize that there is some importance to menstrual hygiene, right? Okay, this class is not going to be on menstrual hygiene. It's not working, is it? That will be actually. Okay, I won't be talking much on menstrual hygiene. This is just for you to understand what we are going to talk next on. Just to have an idea, okay, something about menstruation. We'll talk about menstrual hygiene sometime later. This topic is not really covered, but go back and think about it. What exactly would you tell your patients or someone at home what menstrual hygiene means, what all they are supposed to do. Okay, so we'll talk about normal menstruation and menstrual cycles. Sorry, I'm getting heavy coughing because I'm not well. Can someone from that row tell me what do you understand by normal menstruation? You all had a class, right? Just 2 days back. What do you understand by normal menstruation? Anyone from this room? It still takes, even if you come so late. Anyone? First, second, third, fourth, 5, 6, 7 rows are there. Anyone would like to answer? What is normal menstruation? What do you understand by the term normal menstruation? Yes? At least girls should be able to answer. Come on. There's nothing to feel shy about it. It's a normal physiological phenomenon, right? Pregnancy, menstruation, all these are normal physiological phenomena. As doctors, we should not feel shy. Rather, we should know what is normal. Because I'm sure the moment you're a doctor, no one looks at you as, male or female. They just look at you as a doctor and they'll have a lot of questions. So no one feels shy to ask any such question. So please. What is normal menstruation? Come on. No, ma'am. No one would like to attempt?
Normal menstruation is optimal flow amount and it's got the optimal number of days, like 4 or 5 days. And it comes regularly, like between menstrual cycles of like
nothing, but you're talking more of menstrual cycle. When we talk about, okay, we'll be talking about definition, endometrial ovarian cycle. So when we talk about menstruation, it is basically a regular discharge of blood, right, from the genital tract, which is from the inner lining of the uterus, which flows into the vagina, right? It is to be regular bleeding from the genital tract. So when you say regular, how regular it is? Ideal would be a 28-day cycle, right? Very regular, and with a bleeding of anywhere between 3 to 8 days. Okay, so when you talk about menstrual cycle, there are a lot of changes which occur because of which menstruation occurs. Okay, there is something with the menstruation, there is some which acts on the, something with the hormones which act on the ovaries and uterus. Finally, the menstruation occurs. Okay, there are a lot of changes which are. So there are interrelated. There is a separate ovarian cycle, there is a uterine cycle, and above all this you have a hypothalamo-pituitary ovarian axis which will be controlling all this. So there are changes in all these things which will go on to menstruation, right? Okay. See, these definitions you will get from your textbook. Don't have to write it. So now, what do you think for a normal menstruation to occur? What do you think should be available? Should be there in a human, woman. Ovary should be there, very good. Obviously, uterus should be there, then hormonal balance, then hypothalamo, okay, a very well functioning hypothalamo-pituitary ovarian axis, yes, then normal endometrium, and then what else? Normal passage, okay. What else? Don't you think a karyotyping also should be normal? Others patients, you cannot have an XY karyotype or an XXY karyotype and have a woman menstruating unless she has both. So it can happen. So all these are very much required. Most important thing is you need to have a female karyotype, that is 46XX. Then, as someone said, you have to have an integration of HPO, that is hypothalamo-pituitary ovarian axis. I'm sure this must have been taught to you in physiology. I don't know in 1 year how much you have learned. And a functional uterus. Just having uterus is not enough. Suppose the uterus is not connected. You all know how the uterus is developed. We'll be having in another class. It's developed from various things. Finally, it has to fuse, it has to canalize. Okay, vagina is developed separately, lower part of vagina from a different tissue, upper part of vagina is from the different tissue. There has to be a communication between the cervix and the lower part of the uterus and the lower part, which is the cervix. There has to be communication between the cervix and vagina. When all this is intact, only patient will have menstruation. When we say menstruation, she is actually having bleeding outside into the vagina and outside. She is seeing it. There are patients who may be having menstruation, but it will not be seen outside. Like when you have a vagina which is attentive, or when there is a hymen which is not open, it's totally closed because of the developmental anomaly. Okay, so you need to have a functional uterus, and as I said, a patent lower genital tract. All these are very important for a normal menstruation. Understand? So we'll be discussing mainly about the integration of HPO axis. When we talk about functional patent uterus, we'll be discussing in some other class. Because there are a lot of things which we need to discuss. When we talk about these things, it will be more about anomalies. Okay? So what we'll be concentrating is mainly on the HPO axis. Now if you look at the phases of menstrual cycle, you have an uterine phase, yes, and you have an ovarian cycle. So in uterine phase, there will be menstruation, then there will be proliferation of the endometrium which has been shed already, again it has to regenerate, right? Then you will have a secretory phase, okay? After that again this is a cycle. So corresponding to it you have the follicular phase, you have the ovulatory phase, and you have the luteal phase, okay? So understand, so uterine phase and the ovarian phase, almost things will go on simultaneously. Each is dependent on the other, right? So if you look at this, it will tell you that everything about the menstrual cycle. So menses occur actually in follicular phase. What happens? The follicle grows. Okay, there will be multiple follicles which grow, but finally it is one which becomes dominant. Okay, again I am telling you all this is there in, but the follicle starts developing even before the menstruation occurs almost. Okay, I mean recruitment starts occurring even before the menstruation. So first as menses is occurring, the follicles develop, then in the uterus what will happen? There will be proliferation because of estrogens, mainly because of estrogen, effect of estrogen. Then toward the end it becomes secretory. Secretory is so much so that stroma increases, the vascularity increases. Mainly the whole idea of going into secretory phases, it wants to accept a fertilized ovum. That is the main action. If that doesn't happen, then again the hormones get withdrawn and she will go into menstruation. Okay, so these are the cycle which occurs in the uterus. At the same time, what happens as the proliferation is occurring, the ova gets recruited and finally they mature and ovulation occurs. Once the ovulation occurs, there is something called as the luteal phase, where the corpus luteum supports, gives progesterone for the, if at all pregnancy occurs, it will support it. Suppose pregnancy doesn't occur, even that corpus luteum will cease and it becomes atretic. Again it will go on to that time all the hormones will decrease and finally she will go in for menstruation. Okay, this is the cycle which we'll have to see. Okay, now coming to physiology, brain, most important hypothalamus, right? So what will it do? It will secrete gonadotrophin releasing hormone. Basically you have to remember three: hypothalamus, pituitary and ovary, right? In hypothalamus it is GnRH which acts on the pituitary to regulate two hormones, follicular stimulating, luteinizing hormone. Follicular stimulating hormone is necessary for acting on the ovary, okay, and acting on the endometrium so that the endometrium develops, follicles develop, okay. Whereas luteinizing hormone is necessary for ovulation to occur. That much if you know, it's enough. Then of course they will act on the ovary to release estrogen and progesterone. So basically you remember this much, it's enough: GnRH, FSH, LH, then you have estrogens and progesterone. Okay, so GnRH will act on the pituitary, it will release FSH and LH. So what it will do? It will act on the ovaries to release estrogens, progesterones and androgens, which are finally necessary for the development of the follicles. Okay, FSH is development for the follicles and estrogens also are necessary for the proliferation of the endometrium. And as the ovulation occurs, the progesterone levels go up and the estrogen levels slowly come down. It won't become absent. Both are necessary to maintain. Finally, the progesterone levels go up at the time of ovulation so that the endometrium is developed well enough to accept a fertilized ovum. Okay, so that's what happens. And anti-Mullerian hormone is something very important because it is secreted by the cells. That will tell you how functional the ovary is. That's what we will talk about. Okay, so what will happen? Ovarian hormone production, as I said, we have LH and FSH. Then LH acts on T-card cells and in the progesterone phase. Then you have FSH which acts on the granulosa cells, and finally what will happen? Testosterone and aromatization occurs. Whereas here granulosa cells will release estrogen and inhibin. This inhibin again is necessary for maintaining the levels of FSH. Okay. And finally what happens? All this will act and get converted to estrogen. Okay, so this is what is very important. Look at this picture, you will understand. This is a growing follicle and finally this is the corpus luteum, and finally when it becomes atypic, it becomes the corpus albicans. So the body temperature just before ovulation there will be a small fall and there will be raise. Then what will happen to the pituitary hormones? Okay. You look at this is the LH, this is the FSH which goes on acting. LH will increase just before the time of ovulation. That is necessary for it to act on the follicle and release the ovum. Okay, then you have the what is this? Estrogen, and this is the progesterone. Initial part of the cycle you need the estrogens which will help in the development, that is the proliferation of the endometrium and also development of the follicles. Then you have the progesterone, which will help further increase the stroma and also the vascularity of the endometrium, so that, as I said, it goes into the secretory phase. So this is what happens. Then finally in the endometrium, as we have already told, menses, that is the, what is follicular phase? It's basically from the day of menstruation till ovulation. Okay. Then ovulation occurs, then after that will be the secretory phase of the, or the luteal phase of the endometrium. Okay. So coming to the, you have understood, basically all these hormones act together. FSH rises, okay, it will keep on rising, estrogen rises. The moment it's time for the follicle to be matured, LH acts on the ovary to release the ovum. Then slowly estrogen levels fall, progesterone levels rise. That will maintain the, the corpus luteum maintains the progesterone, and also this progesterone is necessary for the endometrium to maintain a milieu so that the fertilized ovum gets implanted. If that doesn't happen, there will be withdrawal of all the hormones, menstruation will occur, FSH will fall, and again slowly all these hormones will fall. Once menstruation occurs, then the lower levels of estrogens will again make the FSH levels rise. These levels will again make the estrogen levels rise, so that the follicles keep developing. So it is a balance between these two. One level rise, the other falls. Once this falls, the other one will rise. So it will keep acting interdependently. Okay, so if you look at the normal menstrual cycle, there were various definitions. Earlier it was between 21 to 35 days. Now the definition has changed from 24 days to 38 days. Why it happens is, on each time someone does a study and they find this is normal. So this keeps changing. So duration of flow, earlier we used to say 2 to 8 days. Now it is between 3 to 8 days. Okay. Then amount 30 to 80 ml. Remember, this amount will never calculate. It's an approximate thing. Okay. An individual, when do we say, we never talk in terms of amount. Amount is difficult to measure. That means each time the patient has to weigh her pads, should tell us whether it is fully soaked, partially soaked. So it is basically, this is the amount which is lost, but for measurement or day-to-day management, we don't really look at the amount. We look at the number of days of flow, and also we'll see what is the length of the cycle. Of course, yes, indirectly we measure the amount, as I told you, by asking them how many pads are soaked, what is the amount of blood loss, whether she is having clots. If clots are forming, that means the amount of blood loss is more. And if she is having any associated symptoms, obviously a patient will be, if you think the blood loss is more, you may clinically assess her, and necessary, you may do even the investigation to find out what is the hemoglobin level. But most of the time, we just ask them the cycle length and the duration of the flow. Okay? So this is normal. Remember, everyone may not have the same cycle length, everyone will not have the same duration of flow. Suppose a girl or a woman has a 28-day cycle always, for her a 35 or 38-day cycle is lengthier. Okay? Or if she has a 22-day cycle, for her that cycle is shortened. Agree? It's not that for everyone we take this into consideration. It depends on each individual. This is the average length of the cycle any woman can have, but you also have to ask how her cycles were. You cannot just go by, okay, 38-day cycle, you had 22-day cycle, now 38 days, it's fine. It's not like that. You have to assess for each individual woman. Likewise, the duration of flow. It's very important to ask her how many days she bleeds. Suppose she is bleeding for 4 days and now she has started bleeding for 8 days, that is abnormal for that woman. Likewise, if she has never had clots and now she started having clots during periods, that is also abnormal. So all this has to be taken into consideration when you talk about the length of the cycle and the duration of flow in a woman. Okay? Then proliferative phase is between 14 to 21 days. Means not between, the duration could be anywhere between 14 to 21 days, again depending on the length of the cycle. And the secretory phase usually is fixed for 14 days. That means prior to the onset of menstruation, the prior 14 days is secretory phase. Usually it is seen that ovulation occurs 14 days prior to the onset of the menstruation. But again, now this theory is also changing. It is not really constant. Okay. Menarche should occur anywhere between 10 to 15 years. If it occurs before that, you usually call it as premature menarche. If it occurs later, then you will have to find out what is the cause, why is it getting delayed. But again, you have to look at the family history. In some families, they may attain menarche at 16 years of age also. I'll come to it a bit later. And menopause, if you look at India, it is anywhere between 40 to 52 years of age, but average age at menopause is 47 years. Now coming to menarche, usually till 14 years we wait if the girl has developed secondary sexual characters. Nowadays, if you look at most of the girls, by the age of 12 years, most of them attain menarche. Mothers start getting worried if the girl doesn't attain menarche by 13 years of age. Okay, that because the trend has changed towards the earlier side. But again, if the girl has developed secondary sexual characters, we tell them not to get worried, and we can always evaluate her after 16 years, because there may be a delay in menarche. If you ask the family history, majority of them would have had a menarche at a later age. Okay, so that is very important. But if she doesn't have develop secondary sexual characters, then any girl who has not attained menarche by 14 years is a reason to evaluate. Okay, that is very. So this is the characteristic of cycle. If you look at this, see the stroma, it is not very dense. Even these are all the glands which are very small. Not much of changes in the gland. If you look at the secretory phase, dense stroma, there is a lot of proliferation in the glands, and what is more important is there is secretion in the gland. So this milieu is important when this is a normal histology. It's very important for a woman to be pregnant. If there is any alteration in this, then there may be infertility in the woman. One of the causes. Okay? If secretory phase doesn't occur at all, that means patient is having anovulatory cycles. Okay? The secretory phase may not be very effective. Even if it is, it may be shorter. Usually, that is the anovulatory cycles may be because of increased estrogen levels. There may be some problem with other hormones. LH is not being secreted, ovulation is not occurring. So, again, progesterone is not being secreted adequately, and the endometrium is not developed enough. So, these are the problems with maybe with infertility. So, that's why it's important for us to know whether her endometrium is also very well developed. It's not just enough that if she is ovulating, there will be problems at all levels. And the endometrium should be receptive enough to accept the fertility hormone. If that does not happen, whatever you do, again, implantation may fail. Okay, so if you look at an ultrasound during menstruation, can you see this? This is the, are you all able to appreciate? Okay, this is the uterus, this is the normal texture of uterus. If you look at it, this is the endometrium. This, as you're going up, it is the cervix. Okay, this thin lining is the endometrium. Obviously, during menstruation, it will be very thin because the endometrium is being shed. So this is in the early proliferative phase. If you look at the thickness here and thickness here, definitely see this thin, maybe people behind may not be able to appreciate, you will be able to see. And this is at the time of ovulation. Can you see the triple layer? Okay. This will be from one of the walls and this will be the center. So this is the typical appearance of a endometrium at the time of ovulation. Okay, and finally at secretory phase, can you appreciate the difference between this endometrium and this endometrium? It's more thicker, and if you put the Doppler, the vascularity will be very close to the endometrium. This is a very good endometrium if in case she becomes pregnant for implantation to occur. Okay, so again this is pictographic representation of your ovarian cycle, how follicles develop, ovulation occurs, corpus luteum maintains till the time pregnancy occurs. If it doesn't occur, it will undergo atretic and becomes corpus luteum. Okay, now coming to the number of oocytes. This is also important for us to know. how many oocytes the woman should have. Any idea? You all would have read in your. How many hundreds, thousands, lakhs, millions, or whatever number of oocytes should be there at birth? When do they start developing? How early, how late during? See, it starts during the intrauterine life itself, right? All that is decided during the intrauterine life. Any idea? 300, 400, 500. How many should be there? No, ovulation later. See, what happens is you have so many of that during every cycle. Many will get recruited. Only of that one will become mature. Sometimes two, sometimes three. Very rarely three. Usually it is one or two. Maximum, usually one, two, maybe three maximum. Never we can have four ova maturing at the same time, until unless we artificially induce something. That can happen. Like when we do IVF, in vitro fertilization cycles, we don't want just one ova to develop. It's not going to help us. We need to have many more ova, because you collect all those and finally we don't know how many will fertilize. If you have 10 ova, 5 may fertilize. Of the 5, only 2 may develop into good embryos. That's what happens. It's not that all 10 we take in good quality, because even remember the ova also mature at different times. So when we are retrieving, some may be still immature cells. Only 1 or 2 may be mature. So there are a lot of things. So in those cases we need hyperstimulation. So whenever you are doing IVF, it's not one ova if you get, we are nowhere. Because even if embryo forms, almost that means the quality may not be good. That's why many are not forming. If you have at least 4 or 5, you are happy. If one fails, at least you can put other fertilizer. So if you look at it, the number of oocytes are between 6 to 7 million. Okay, and they peak at 20 weeks itself of intrauterine life. They start developing, but the peak number will be at 20 weeks of intrauterine life. So 6 to 7 million. It's not in 100, it's not in 1000. Okay, slowly they start becoming accretive, and at birth from 6 to 7 you have only 1 to 2 million ova left. Okay, then what happens? At puberty it's just become 3 lakh, totally available at 3 lakh. So though many are developing, slowly they start becoming accretive. And finally you have around 400 to 500 available for ovulation. If you have anovulating cycles, then that number, this is the normal ones. You can have abnormal ones where the number of ova themselves are very less. Okay, they hardly may have 100 or 200. So that means their fertility chances will be definitely decreased. Okay, these are the patients who require some assistance. Okay, this is what happens to oocytes. This will be a good question for your MCQs in your what is that? For entrance. I don't know next what will happen. We don't know. Okay. So if not now, at least for your senior resident course. Okay. At menopause, finally you will have hardly any ova left. Sometimes few will be there, but most of it will be dense stroma. Okay. Okay, when we talk about follicular genesis, I don't want you to know in detail, but just remember few things. There is something called a primary oocyte which gets arrested in prophase. Then after that primary oocyte, it is surrounded by primary follicles, okay, which will be a single layer. Then this primary follicle gets into secondary follicle, where the secondary oocyte is surrounded by the zona pellucida. So you have a tertiary follicle, okay. Then it will form the antrum. The ovum will be in the center. You have a primary oocyte, secondary oocyte, and you have the ovum in the center. So this will be the pre-ovulative follicle, which will be the final stage of follicle development, which happens just before ovulation. So usually you will find till secondary follicles there. At the time of maturation, the tertiary follicle forms, and you will have, before ovulation, it will form a full ovum. Okay, so these are the various cycles of development. You have a primary oocyte, secondary oocyte, arrest at that level. Then later on it will develop into the pre-ovulatory follicle around which you have the antrum. Okay, so now how is the selection of the follicle occur? So it usually occurs on day 5 or 7 of the cycle. So what does it depend on? The intrinsic capacity of the follicle to synthesize estrogen. Whichever follicle synthesizes more estrogen, that follicle will finally become dominant. Okay, so the highest estrogen and androgen ratio in the follicular fluid. Also, as the dominant follicle matures, there is increased estrogen, which will give negative feedback to the pituitary. Okay, so that the follicle with highest number of FSH receptors gets recruited. Okay, then other follicles which are not recruited will become atretic. Okay. So this is what happens. See, again remember, follicles will be at various stages. So finally, as we said, primary follicle, secondary follicle, tertiary follicle. So at various stages, it's like some cells decide to grow. So some follicles will, all the follicles will not be at the same level. So for this cycle, maybe 3-4 follicles will decide to grow, or 4-5 follicles will decide to grow. Of that, whichever has these characteristics, that will become the dominant follicle, and others become atretic. Sometimes it may happen that follicle will be a group of cells, right? Whereas you will have one ova in that. Okay. So the one ova which becomes the one cell which becomes the dominant thing, all the other cells become atretic. Finally, only that ova matures and gets in. So follicle has a group of cells, right? So how many groups? It depends. Usually it may be 5 or 6 or 7. Of that, one follicle will become more dominant. Of that follicle, one ova will finally ovulate. That's what happens. Okay. So this is what happens in follicular selection. Okay, same thing. You have so many. Finally, as I said, 4 or 5 will become dominant. Then they will get selected, on of which one of the follicles become dominant, and finally from that follicle the ovulation occurs. Okay. So LH surge. Why does LH surge occur? It occurs so as to facilitate the ovulation. The ovulation to occur, the luteinizing hormone, as I said, FSH is necessary for the follicular development. Luteinizing hormone is necessary for the ovulation to occur. So what will happen? Usually just before ovulation, that is 48 hours or even 36 hours before ovulation, the LH surge occurs. Then the ovulation occurs. After that, for some more time, the LH surge remains, and then once the ovulation process is over, the LH falls down. Okay. So as I said, once the LH surge occurs, 36 hours later, the ovulation will occur. So this, as I said, initially we saw estrogens are more. Okay, the moment ovulation occurs, estrogen will fall down. Okay, this will trigger the assumption of meiosis. That's what I said. Once the estrogen levels slowly fall down, I also said the follicle actually starts getting recruited just before the menstruation. Okay, the next follicle, next group of follicles. Okay, so granulosa cells release the progesterone. This progesterone is necessary for the maintenance of the endometrium to the secretory phase. So each one is dependent on the other. You have FSH, because of which estrogen levels go up. Then as the follicle is developing and the follicle has to mature, that time LH surge occurs. Because of the LH surge, there is ovulation after 36 hours. Once the LH surge happens, then slowly estrogen levels fall. At this time, the progesterone levels go up. This LH is also necessary for the progesterone levels to go up. So it will go on till the time that pregnancy does not occur, then progesterone levels fall. Then again, at this time, if FSH levels are also low, right? As the progesterone levels fall, the FSH levels go up. This is like a negative feedback. Okay, so the FSH levels go up and slowly the estrogen levels go up. and all these are necessary for the proliferation of endometrium and also for the development of the follicles. Just simply remember these. Okay? Too much of theory is not necessary. So finally, how does the follicle rupture? What happens? As you follicle, what does it contain? It contains fluid. As it grows, what happens? There will be tense because of the increase in fluid, it will become very tense. Okay, so there will be increase in follicular pressure. Also, there is change in the composition of the antral fluid. So this will lead to colloid osmotic pressure. Then there is enzymatic rupture of the wall. Then LH and FSH will occur. Then all these, they act on the granulosa cells. Then they produce something called as the plasminogen activator, where there is fibrinolytic activity, and finally entire breakdown of the follicular wall. And just remember, there is increase in pressure, and there are some changes in the osmotic pressures and some enzymatic changes, and finally all these are responsible for the rupture of the follicle. Again, keeping all this in, it's not necessary for you to know this much in detail. These are mainly necessary when we are managing patients with infertility. Just think of how follicle ruptures. Okay, so when is luteal phase? Luteal phase is after ovulation, right? Progesterone peak of 8 days of ovulation, that is around day 22 of menstrual cycle. Earlier, when we had to follow up infertility, when we still didn't have ultrasound, two ways we used to assess whether a woman has ovulated or not. One is, we didn't even have the ultrasound, so we used to look at the cervical mucus. At the time of ovulation, we'll be discussing that at the time of ovulation, because of the increased levels of estrogen, the cervical mucus becomes very thin. It can be stretched as much as 10 centimeters. So immediately after menstruation, the cervical mucus is thick. Then slowly at the time of ovulation, cervical mucus becomes very thin. That's because of the estrogen effect. Then after the ovulation occurs, slowly the progesterone levels go up, and the estrogen, the mucus starts becoming very, very thick. This is the progesterone effect. In fact, these are naturally important because it will also prevent conception from occurring, and most important is, if the cervical mucus is thick, it will prevent any pregnancy losses, because especially infections from occurring in all those. That was the theory behind. So, if you look at the contraception also, how does progesterone act? Mainly, it will make the cervical mucus thick so as to prevent the sperm entry. So that's how you should remember what happens to the cervical mucus. So in luteal phase, and another thing is, we used to see whether the endometrium is actually following the cycle or not. We used to do an endometrial biopsy on day 22. If there is out of phase, that means today it should have been day 22. It is still day 20 or day 19. That means there is some anovulation or something. So that's how we used to correlate. Now all these are redundant. We have better ways to estimate. Best is do an ultrasound and see if the patient is ovulating or not. You don't have to do anything. Earlier we have to do it. It's basically an invasive thing, endometrial biopsy. This is routine we used to do to see if the woman is ovulating or not. If she has proliferative phase, or if it is out of phase for 2 days, endometrium which has to be on day 22, it is still showing a day 19 endometrium. That means it is still abnormal. But now all these, as I said, are redundant. Okay. So corpus luteum is sustained by luteinizing hormone, then it loses its sensitivity to gonadotropins, then luteolysis occurs, especially after 22 days of cycle. By then, if implantation does not occur, luteolysis occurs, then again there will be further fall in estrogen levels, and also there will be fall in progesterone level. So this will lead on to the desquamation of the endometrium, and finally it will end up in a menstrual cycle. This is what happens. Okay. So everything falls. Then as everything falls, then once the bleeding occurs, slowly the follicles also start getting recruited, ready for the next cycle. That's when slowly FSH levels go up, estrogen levels go up. See, now the estrogen fell so much, FSH is also low. It will go to such a situation that FSH will start rising because the levels of estrogen are very low. Once that starts occurring, the when follicles get recruited, slowly the estrogen levels rise. So that is a big cycle. Okay. If pregnancy occurs, there will be HCG secretion and corpus luteum is maintained. If it does not occur, then everything will cease. So, why should we know about menstrual cycles? The regularity always depends on the age. What happens to menstrual cycles usually? In extremes of age, suppose a girl attains menopause, majority of the women, at least 70% of the girls will have anovulatory cycle. Means cycles are usually prolonged. Few of them may have frequent cycles and have heavy menstrual bleeding. That also can happen. Usually the cycles are prolonged at extremes of age. Same thing happens at the time of menopause, premenopausal, what we call as menopause transition. Most of them will have cycles which are prolonged and then slowly they will stop. It's not necessary for everyone. It should be in this pattern. But yes, for majority, cycles are irregular or anovulatory during the at menarche and also at the time of menopause. Okay, so again regularity depends. Suppose this kind of irregular cycles occur in reproductive age group women, then it is a matter for concern, right? Most of the things, what is the problem for them? Obviously childbirth, right? Conception and childbirth is something very important in the reproductive age group. Women are not bothered once they finish their family, but yes, everyone has this concern when people have anovulatory cycles because of conception. Of course, other problems with anovulatory cycles is that they may be having an underlying polycystic ovarian syndrome, obesity. All these are interrelated. Even if they have completed family, imagine if a woman having very irregular cycles, it's very distressing. They can't go anywhere, they can't plan things right, especially if they have to go for some pilgrimage, whichever. Or if they want to go for some outing, it's very important. Someone wants to go for swimming, they can't do it, right? So again, it is necessary that they know about the regularity of the cycle. Okay. So your time of ovulation depends on the menstrual cycle, yes or no? So for natural cycle, we always tell the woman, when does the woman ovulate? If you take a 28-day cycle, around 14th day. So it is very important for us to inform them that they should have sexual activity during around that time so that they will conceive. Most of the times if you look at infertile patients, you take their history, what will they say? Yes, we are having regular coitus, but when? Around just after menstruation, 5th day, 6th day. It's not going to help them. They can have, but what is very important we have to counsel is that at the time of ovulation, they need to have coitus so that they will conceive. So that is very important. So you need to know the time of ovulation. Of course, irregular cycles, you keep thinking, okay, the patient will keep saying, I have always irregular cycles. You won't even know that she is pregnant. So the cycle length is important for us to know, especially in the reproductive age group, whether they are pregnant or not. Many of them may not use any kind of contraception. Okay. Next, coming to contraception. Most of the contraceptives are started just after menstruation or with the onset of the menstrual cycle. You cannot give any contraception in between the cycle, except any deviations to this rule, where you give contraception irrespective of the menstrual cycle. Emergency contraception, okay? Especially for women with menstrual and they've had coitus and she's worried, we tell them to use some kind of emergency contraception. But remember, emergency contraception should not be used as a regular contraceptive. Once in a while it is okay, especially for people who oddly meet, okay? For them it is okay, but it should not be a regular. It's not that, okay, now we use every time we use emergency contraception. That should not be the rule. That has to be told to them. Okay? So otherwise, most of the contraceptives are, if it's oral or injectable, usually orals will be started on day 1, injectables will be given within 7 days of menstrual cycle. Or even if you want to insert IUCD, it is preferable that to do that. Even sterilization, the idea is you have good contraception or ask them to use. If you do it after ovulation, what would have happened? They might have already conceived. So the contraceptive is going to be a failure only. So ideal time is within 7 days of menstrual cycle. Okay, again infertility, as I've already told you, it's very important to know the length of the cycle, whether we should look at their natural cycle, to monitor. Everyone may not ovulate at the same time, so for that it is very important. Abnormal uterine bleeding. As in the beginning itself I said, each woman has a different pattern of bleeding. What is normal for one person is abnormal for another person. So if you know the normal length of the cycle, if you know the generally normal length of the cycle and the duration of flow and how much amount they should bleed, and with respect to individuals, it's important for us to find out whether is their bleeding only really abnormal or is it a normal pattern. Okay. Of course, menopause. Again, suppose as I said, after 42 years, if a woman says I am not getting a period, most likely it could be into menopause. But again, not be too sure. We can have pregnancies occurring even at 42, 45 years of age. It's not impossible. Any idea what is the maximum limit where we can do a assisted reproductive technique as a method for conception? What is the maximum age for a woman? Say 50 years. So when it is acceptable for a woman to become pregnant through these techniques to 50 years, she can naturally also be pregnant, right? So till menopause, until unless I use some contraception, nothing prevents a woman from becoming pregnant. So of course, after 40 years, we think more in terms of menopause rather than pregnancy. So this is the importance of why we should be knowing about the menstrual cycles. Okay, this again summary of what you have already learned. There is a correlation between the hormones, between the ovarian cycle and the endometrial cycle, which happen during the normal menstruation. Okay, if you just remember this is enough. What is important is FSH, LH, then the estrogens, progesterones. You can see estrogens peak at the time of ovulation, then fall, progesterone slowly rises. Same thing, FSH, small peak at the time of ovulation, but what is more important is the luteinizing hormone. And there is a small fall in temperature just before ovulation, just around 5 degree Fahrenheit, 2 degree Fahrenheit fall before ovulation, then again it will rise. Earlier we used to use basal body temperature also to monitor. Again it's very difficult because it has to be tested just before the woman comes out of the bed, doesn't take anything orally, she should not be having fever. So that's not a very good method to assess. Now we have best method is ultrasound to assess the ovulation. Okay, then the follicles which form ovulation, after that corpus luteum, it sustains if pregnancy occurs, otherwise it will become atrophy. So this is about a normal menstrual cycle. Any questions for you? This much if you remember, this is enough. You don't have to learn in detail about those things because such questions, maybe now I don't know what is the pattern of next, at least MCQs we used to think, but for you people what will be it, we don't know. Are you going to have MCQs in your next pattern? How many short, full thing is on MCQs, is it? But that is the final exam. What about clinics? Clinics is not included for selection into post-graduation. That cannot be. No. No, next two is only for you to finish your internship and get the degree. But I don't think clinics is involved for you to get into a post-graduation anyway. If that is there, we are in suit. Right, every medical college will do what they want. If I want, we just pour marks for me. That won't be correct. This will be only MCQ pattern, next one. When is it? At the end of final year. So that you'll at least, the idea is you'll work during your internship properly. Don't give an excuse that we have exams to study in Oxford. This December, isn't this? From your batch. No idea. Next class will be talking something about normal. I mean, there are various classifications. I've just told you the gist of what it is, but how we actually classify. There are various systems of classification of normal and normal uterine bleeding. We say frequency. I've just told you the gist. So we have something called a FIGO classification of abnormal uterine bleeding. We have class 1 and class 2, which talks about normal and abnormal. It is basically playing with words. Next class, Dr. Kubera will be covering on abnormal uterine bleeding. So, I mean, before I close, this has nothing to do with the class. There are certain things. All of you know that you have to submit your record. You have got your record or no? So, the record has various things. It's labor room, whatever you're managing labor room, you have 10 cases which are. See, don't just copy paste from someone. The idea is this will be a good thing for you to even during clinics, how to take history, how to manage, everything is very comprehensive. Same thing for your gynae cases and antenatal cases. See, if you start writing, seeing all this, then you don't have to really go back and read books. That's what I was telling few of you who were there yesterday. I'm not sure they are here. Labor room is a fantastic posting, whatever you get those emergency postings, because entire obstetrics you can learn from your patients. You don't have to really read books, especially the clinical management. Maybe little bit of theory is necessary from textbook. Whatever management, how to monitor, how to take care of patients, all this, you see that you will remember and write in exams. You don't even have to, read for that. That is the greatness of obstetrics. Everything is learned in emergency. And if you don't learn in JIPMER, you will never learn anywhere else. The number of patients, the number of hands-on you get nowhere else, people get this much hands-on experience. You are allowed to touch patients, patients are happy when you are taking care of them. You are allowed to conduct deliveries, which episiotomies, monitor. Okay, all this, please take full advantage of this situation. Outside, they are not even allowed to enter labor room and see what is happening. Here you are allowed to do things on patients directly. They are not doing on simulators, they are directly doing on patients. So please take full advantage. At the same time, be nice to them. They are the ones who teach us a lot. All of us are today at this position, it's because of the patient. So please take advantage, don't abscond, whether it is labor room, whether it is HDU, whether it is ICU, whether it is eclampsia room, you get to learn a lot. You people have to take initiative to see patients. No one will come and say, come and see. You go through the case sheet, see what is written, how they are managing, ask questions to residents who are there. No one may have the time to call and talk to you, but you people should ask them. You people see how they are managing. It's not about conducting deliveries, it's not just doing episiotomies. If you identify a problem, you also should know how to manage. Someone identifies that there is a fetal heart of 118 next. It's not enough that you just tell the JR and walk away. You also should know how they have managed. What is the problem? Why is there fetal tachycardia? What should you do if no one else? There will be situations, especially when you are posted in peripheral health centers, Ramnathpuram, or you are in casualty when resident is not available. You may face such situations and you will have to take decisions. How do we know? Many of you may want to become primary care levels or joint family medicine. So all this will become very, very important. So please take full advantage, and JIPMER is the best place to learn. Whether it is surgery, OG, medicine, pediatrics, I'm sure you get lots of hands-on experience. Okay, and be on time, follow rules, follow regulations, then you will be happy to learn any subject. Thank you.